Hi guys, today we're going to talk about PE or pulmonary embolism. So again, let's start with definition. So a definition of a PE is simply like a clot in the pulmonary arterial circulation. So it's a clot in the arteries or in the arterioles of the pulmonary circulation. So the circulation in our lungs. So where does this clot come from? So the most common source of this clot is from our deep veins, so the deep veins of our lower extremities, of our legs. So let's just remind ourselves what these deep veins are that I'm talking about. So obviously the big veins, the deep veins, we have the superior and inferior vena cava. So the inferior vena cava branches off to the left and right external iliac veins. As I was saying, you have the inferior vena cava, which then branches off to the left external and the right external iliac vein, followed by the femoral vein, and then the popliteal vein at the level of the knee. And then from there, it branches off to the anterior tibial, the posterior tibial, and the fibular, or there's another name for it. I can't remember, but it's the fibular vein. Peroneal, I think, is the name for it. So those are the deep veins of our legs. So a thrombus can form in any of these deep veins, and this thrombus can then break off, and now it becomes an embolus and lodge itself somewhere in the pulmonary circulation. So again, for instance, we develop the clot somewhere in the just below the popliteal vein, just below the level of the knee. It can break off, and from that, because it can travel up from the popliteal vein to the femoral vein to the iliac vein, into the inferior vena cava, into the right side of the heart, and the right side of the heart pumps blood to the pulmonary circulation. So that's how it ends up in the pulmonary circulation. Other potential causes include maybe like an air embolus. So this is most common in like diving and in divers. So when they resurface really quickly, they might get an air embolus called it's called decompression sickness. Or if you're in the hospital and someone introduced like air directly into your arterial circulation, maybe via syringe or something, then again that can cause an air embolus. Another one can be like because of long bone fractures that may introduce like fat embolus into the pulmonary circulation. Also during pregnancy, some contents of the amniotic fluid, like of the amniotic sac, so like the amniotic fluid or some fetal material, can get and can lodge into the pulmonary circulation, causing a PE. The last potential cause of this clot can be from like bacterial embolus. So for instance, like someone is an IVDU, like an IV drug user, and they've introduced bacteria in the circulation, so like Staphylococcus aureus, and that can then take residence somewhere like around the tricuspid valve area, and then they form vegetations, they grow, they multiply, and then they can break off and lodge into the pulmonary circulation. An important thing to remember is that these clots can be of different sizes, so they can block like the small arterioles or bigger arteries in the lungs, or even the main pulmonary artery. So if you get like a saddle embolus, it usually blocks the main pulmonary artery, where it bifurcates to the left and right branches. So you can get a massive clot there, which is called a saddle embolus. Since we're talking about the causes of a PE, and I mentioned that DVT is the most common cause, I think it's important for us to discuss what causes a DVT initially anyway, which may then turn into a PA. So do you remember Virchow's triad? So we have three factors that when like one of them is present or combination of them is present, it increases the likelihood of forming clots. So components of Virchow's triad include the stasis of the blood, which means the blood is not moving much. So blood is not supposed to be static, it's supposed to be flowing. Okay, so if we have stasis of blood, then that increases the risk of forming clots. The second one is a hypercoagulable state. So you can see this in one of two scenarios. So you can either have an increase in like procoagulant activity, which means you're more likely to clot, or you have a decrease in anticoagulant activity. So you have decrease in like proteins or agents that prevent the clot from forming in the first place. So that if you have one of those, then you are more like you're said to be hypercoagulable. So that's the second one. The third one is endothelial injury. So in endothelial injury, the reason why this is a factor for a clot formation is because when we have injury in our endothelium, our platelets are circulating in the bloodstream, and they love to stick to areas where there is damage in the endothelium. So it basically, endothelial damage just gives platelets like an opportunity to stick to the endothelial lining, which can then form clots. So again, we have stasis, we have hypercoagulable state, and we have endothelial injury. So really quickly then, let's discuss some of the reasons for the stasis of the blood. So you remember this is the first component of Virchow's triad, stasis. So why might we see stasis of blood? So if the patient is a post-op patient, or they've had major surgery and they should be on bed rest, they're not mobilizing a lot, they're not ambulating much because they can't. So in this scenario, because they're just not moving so much, there's a higher chance for the stasis of the blood. Also, if someone is like immobilized for for some other reason, like if they are paralyzed, if they've just had a stroke and one side of the body is paralyzed, then they can't really ambulate so much, they can't really walk so much. If they've had like a fracture, in like a big fracture, like if they broke their tibia or their femur or their knee, I don't know, then they can't walk so much. So again, that reduces their ability to ambulate, to walk, to move. So that increases the risk of blood just being static. Another one is if someone travels for a very long time. So if they're on the plane for more than 8 hours, because they're just sitting on the plane, they're not moving so much, again, this increases the risk for stasis of the blood. I've definitely experienced this going back to the Philippines, so it's a 12-hour plane journey. So I try move as much as I can, but it's difficult sometimes. Also, it doesn't even have to be just plane. What if it's car rides? You're just sitting there for so long, and you're not moving so much. This is why like taxi drivers, coach drivers, they're at a high risk for clots because they're not moving so much. They're just sat in one position for the entire shift. And this increases, the risk of forming clots because their blood is just static. It's not really moving. So, I don't know how to best explain this, but I hope you appreciate that the arteries they're like a high pressure system because of the action of the heart pumping. But in the veins, it's such a low pressure system, and they actually have to work against gravity to pump blood back up to the heart. So this is a really demanding task for the veins. They are a very low pressure system. They have to work against gravity. They have to pump blood back up to the heart. So, and there's no pumping action to help them with this. So like we are designed to move, and around the veins we have skeletal muscles. So for instance, in our leg we have our calf muscles. And every time you walk, you stimulate these calf muscles, and the stimulation of these muscles help kind of like propel the blood back up. So this is called muscular milking activity. I swear to God, I didn't make this up. This is called muscular milking activity. So when you're ambulating, when you're walking, when you're doing calf races, or when you're going to the gym, walking to uni, just walking and moving, this increases your muscular milking activity, which then helps you propel the blood in the veins back up to the right side of the heart, so it doesn't go static. So if you don't move, then you decrease the muscular milking activity, and blood is not gonna, it's gonna be more difficult for that blood to get back up to your heart. Another adaptation of our veins to help us with this is they have venous valves, right? And actually, another reason for blood stasis is when we have incompetent venous valves. So we actually see this in patients with like varicose veins. So this is like their problem. They have very incompetent venous valves, so blood tend to stay in that area. Also, if someone is pregnant, so in pregnancy, obviously we have a growing baby inside, and the uterus tends to compress the iliac vein. And if you compress like the iliac vein, then it squishes the vein, so blood can't really move that well through that vein. So again, that may promote stasis of the blood. Also, if someone is very obese, so if they have like lots of like central adiposity and just like fat and like like adipocytes and like tissue around the veins, they may compress on some of the veins, and again, compressing the veins makes it a lot more difficult for blood to actually pass through that vein, which again may promote blood stasis. The second component of Virchow's triad is hypercoagulability. So like I said, this can be because of either increase in procoagulant activity or decrease in anticoagulant activity. So in terms of, so we can get this because of genetic causes, or we can acquire this. A genetic cause for an increase in coagulant activity can be factor V Leiden. So in these patients, they are more likely to form like thrombus, and therefore form a clot in the deep vein or somewhere else that can lodge into the pulmonary circulation. A genetic cause that may decrease their activity of anticoagulant enzymes can be like factor C, no, so protein C and protein S deficiency, or like a deficiency in antithrombin 3. Some of the acquired causes of hypercoagulability include again, pregnancy or taking oral contraceptives with estrogen. It has to contain estrogen, because estrogen, what it does is it can increase the procoagulant activity of such enzymes, and they can decrease the anticoagulant activity of certain enzymes. Another one can be malignancies. So the more specific ones would be like lung and pancreatic cancer, contributing to like a hypercoagulable state of the blood. Another one can be genetic or acquired actually. It's called antiphospholipid syndrome. So in this syndrome, the body creates like antibodies that attack protein C and protein S, which will then decrease the anticoagulant activity of these enzymes. Another one can be like nephrotic syndrome. So in nephrotic syndrome, you're peeing out a lot of proteins. So this may include antithrombin 3, which then again will decrease your anticoagulation activity. The last component of Virchow's triad is endothelial injury. So again, there's so many potential causes of damage to the endothelium. So this can be iatrogenic or non-iatrogenic. So I'll just give you one example. So an example of like an iatrogenic cause, which means from medical procedures or treatment, can be surgery. Obviously, surgery, you cut someone, you damage their endothelial layer. A non-iatrogenic cause can be smoking. Smoking can actually induce like cytotoxic damage and damage to the endothelium. Now let's talk about the pathophysiology of APE and some of the clinical manifestations. So I want to start by discussing the pathophysiology of a DVT, because usually PEs, like I said many times, come from a DVT. So a DVT is just like a clot or a thrombus formed in one of the deep veins in the lower extremities in the legs. And if we have an occlusion in one of the deep veins in the legs, what can happen is that plasma from the bloodstream can then leak out to the tissues around it. And that can cause swelling, redness, and pain in the affected leg. Okay, usually this is in the calf region. So one of the signs that you can utilize is called the Homan's sign, which may be painful for the patient because what you're doing is you're basically assessing, obviously, the swelling, redness, and the patient's complaining of pain in one of the legs. Usually it's just one leg that's affected because it's very unlikely for you to get DVT in both legs at the same time. It can happen, but I think it's very rare. So in the affected leg, what you can do, the one that looks swollen and red, you could dorsiflex the foot, and if that causes intense pain, then this is a positive Homan sign, which may indicate a DVT. It's very non-specific, sometimes maybe non-ethical because you're inducing pain, but anyway, it's still a sign of a DVT. Also, that clot can then break off and travel upwards, making its way back to the right side of the heart. And when it gets to the right side of the heart, that gets pumped to the pulmonary circulation. So now we're in the lungs. And when this clot blocks an artery or an arterial in the lung, what can happen then is it can affect the VQ ratio. All right. So remember, VQ is ventilation to perfusion. So ventilation would be normal in this case, but perfusion would be significantly affected because of that obstruction, that clot, that block. If we have blocked arterioles or arteries because of that embolus, then not a lot of red blood cells can get through that artery or that arteriole, meaning that we would see signs of hypoxemia. So another thing with this, because as I said, ventilation is not affected. So our V in the VQ ratio remains high, but the perfusion, because of the clot, is decreased. So we have a high V and a low Q. So what this creates then is this increases the alveolar arterial gradient, which means this is basically just a measure of the oxygen concentration in the alveoli, versus the oxygen concentration in the arteries. So because we have an increased alveolar arterial gradient, it means that we have more oxygen in the alveolar system versus our arterial system. Because we have hypoxemia, because of that occlusion, that clot in the artery or the arteriole in the lung, what we're gonna get is we're gonna get the stimulation of our peripheral chemoreceptors. So if we are in a hypoxemic state, which means low concentration of oxygen in our arterial system, this is going to stimulate our peripheral chemoreceptors, which are located in our carotid and aortic bodies. These chemoreceptors are connected to cranial nerve 9, which is the glossopharyngeal nerve, and cranial nerve 10, which is the vagus nerve. And then they relay this signal, this hypoxemia signal, to the brainstem, which then what it does is sends like signals back to the lungs, to the nerves innervating the lungs, to increase our respiration rate, and to increase the depth of respiration. So breathing rate and breathing effort. So because we're increasing the respiration rate, the patient becomes tachypnic, increase in respiration, and which means that the patient is hyperventilating at this state because you increase the respiration rate, you hyperventilate. And when you hyperventilate, you lose a lot of CO2. You blow a lot of CO2 out of your circulation because you're hyperventilating. And this leads to an increase in the pH. So this leads to an increase in pH, which is respiratory alkalosis. Okay, so let me say that again. Hypoxemia. Why do we get hypoxemia? Well, there is a clot in the artery, or in one of the arteries or arterioles, or multiple arterioles or arteries in the pulmonary circulation, which means that not a lot of red blood cells can go through and get oxygenated. So we drop the concentration of oxygen in our arterial system. This hypoxemia triggers, they stimulate the peripheral chemoreceptors located in our carotid and aortic bodies, which relay signal via the glossopharyngeal and the vagus nerve to the brainstem, which responds by increasing our respiration rate, meaning we get tachypnic and our depth of breathing, or our breathing effort. When we become tachypnic, we're blowing out a lot of CO2, which leads to respiratory alkalosis, which we can then see as an increase in pH if we do like a blood gas, an ABG. Also, because we are hypoxemic, this is gonna trigger a reflex response to increase our heart rate. So we're gonna be, on top of being tachypnic, we're gonna be tachycardic as well. We're gonna increase our heart rate. Also, hypoxemia can manifest as shortness of breath or dyspnea. So this is one of the clinical manifestations of a PE. Another thing that happens is this clot that is now lodged in our arterial or in our artery somewhere in the lung. What that clot does is it releases certain compounds like thromboxane A2 or ADP or 5-HT, which is serotonin. So thromboxane A2, 5-HT, and ADP, what they do is they stimulate vasoconstriction of the airways. They stimulate bronchoconstriction, and this actually makes the shortness of breath problem, the dyspnea problem, even worse, because if we're bronchoconstricting, obviously, it's going to be harder for us to get air in. But more significantly, what this is trying to achieve is it's trying to shunt blood to other alveoli with better perfusion. Because we have that clot there, that's releasing all of these chemicals to induce bronchoconstriction. And again, that makes the shortness of breath worse, but what it's trying to achieve is to try vasoconstrict the artery that's going to this alveoli, which has that capillary that artery that has that clot. So it's trying to limit blood flow to that region and shunt blood elsewhere to other alveoli with better perfusion, with a normal VQ, not with a reduced Q, not with a reduced perfusion. So that's what it's trying to do. But then what that does, that vasoconstriction, it increases the pressure in that artery. It increases the pressure in the pulmonary circulation, which then puts strain on the right side of the heart. And this vasoconstriction, what it can also do is it can also, if it vasoconstricts so much, it's gonna limit blood flow to the area distal to that clot, and that may lead to the ischemia and the death of that tissue, like the infarction of that lung tissue. It can lead to the rupture of the alveolar membranes, which can then mean that blood can leak out to the alveoli, and the person can cough this up, and we see this as hemoptysis. So coughing and hemoptysis, they're other clinical manifestations of a PE. As I mentioned earlier, the bronchoconstriction in the lungs, because of the chemicals like the ADP, the thromboxane A2, and 5-HT that's being released by the clot, that induces bronchoconstriction, right? And this happens in the entire lung. And if you're also vasodilating a lot of the vessels in the lung, a lot of the arteries in the lung, that raises the resistance and therefore raises pulmonary pressure. And if you raise pulmonary pressure, this puts a lot of strain on the right side of the heart, because now it has to accommodate to pump against that higher pressure. So what it does is it tries to accommodate by getting bigger, but over time this can lead to left ventricular dysfunction. And when we have a dysfunctional right ventricle, it can get dilated, which means it can decrease in contractility, because if you have a dilated chamber, it's not going to contract so much, so you decrease systolic volume, you decrease stroke volume, which then decreases cardiac output. If you decrease cardiac output, what do? You induce systemic hypotension, and systemic hypotension can be another clinical manifestation of a PE. Also, with the right ventricular dysfunction, because it's not pumping blood efficiently to the lungs anymore because there's such a high pressure in the lung, what tends to happen is the blood backs up to the vena cava, up to the jugular veins. So we're gonna see signs of like jugular venous distension. Again, potentially another clinical sign of AP. Just to summarize everything we've spoke about the pathophysiology and clinical manifestations, I just wanna name the like clinical manifestations. So firstly, what we can have DVT, which will present as like, you know, unilateral swelling, redness, pain in one of the legs, and again, positive Homan sign if you want to do that to your patient. And then the second one is the hypoxemia because of that clot. It's increasing the so hypoxemia is going to manifest as shortness of breath or dyspnea, don't forget that. And because of the occlusion, it's going to increase the alveolar arterial gradient, which means that we're going to see much higher concentration of oxygen in the alveolar system versus the arterial system. Because we are short of breath, this is going to trigger the peripheral chemoreceptors in the aortic and the carotid bodies. It's going to send, you know, the signals via the glossopharyngeal nerve and the vagus nerve to the respiratory center to increase respiration rate and depth of respiration. If we increase our respiration rate, we're going to be hyperventilating. If we're hyperventilating, we're going to blow off a lot of CO2. And we can see this on the ABG as respiratory alkalosis, increase in pH. After that, we spoke about the damage to the lung tissue distal to that clot. So we might see infarction of lung tissue, which may lead to, you know, rupture of the alveolar membrane. Blood can leak into the alveoli, so the person may be coughing up blood, called hemoptysis. So that's another classical sign. And then after that, we spoke about the right ventricular dysfunction because there's going to be a high pressure in the lung because of, you know, the ADP, the serotonin, and the thromboxane A2, inducing bronchoconstriction. So we're going to have a high pressure in the lung, and that's going to put strain on the right ventricle. So we're going to see signs of right ventricular dysfunction, like systemic hypotension and JVD. And finally, because we are hypoxemic, this is going to create a reflex tachycardia. And I forgot to mention as well, the patient may also present with pleuritic chest pain. Let's move on to the diagnosis of a PE. So obviously we need to order like the routine tests, so like CBC, BMP, and then we can order like an ABG as well, arterial blood gas, just to check for that respiratory alkalosis if the patient is hyperventilating. We can also check for D-dimer. So D-dimer is like a fibrin degradation product. So recall that fibrin is that mesh thing that forms on top of, like, on the surface of activated platelets, and they kind of like form this mesh on top of the platelets and support the growth of the thrombus. And we have an enzyme called plasmin that wants to break down this fibrin, and this plasmin is just present in our bloodstream, you know. And if plasmin is breaking down fibrin, then one of the products of that degradation, of fibrin degradation, is a D-dimer. So if we have a clot, especially if it's a big clot, then we're gonna produce a lot of D-dimers. So this can be elevated in cases of a DVT or a PE. But you have to be cautious because this can have like false positives. D-dimer can be elevated in other situations, not related to thrombus or an embolus. So it can be elevated when someone is just really old, like in advanced age, if someone has like any malignancies, even if when someone is pregnant, in certain infections and like inflammations, D-dimer can also be elevated. We can also order an ECG. The most common thing we'd see would be tachycardia. So again, this is because of that reflex response to hypoxemia, where the body's going to try to raise the heart rate to try solve this oxygen problem. So apart from tachycardia, we might see, it's called S1Q3T3. on the ECG. So S1 means that there's going to be deep S waves in lead 1. Q3 means there's going to be deep Q wave in lead 3. T3 means there's going to be inverted T waves in lead 3. So this is the S1, Q3, T3, okay? And this is this can present in pulmonary embolism. Also, with the PE, we may see like a right bundle branch block and right axis deviation as well. In terms of imaging studies that can be done to diagnose APE, the gold standard is CTPA, so CT pulmonary angiogram. So this is an invasive procedure, so it involves like injecting some contrast dye into the pulmonary circulation. So the vessels, they all should look black once the CTPA is done. And if there are any like lighter areas, like gray areas, then that indicates that that bit probably is occluded. Okay, so it's really hard to show you without like a picture, but just remember that the vessels, they all should appear black on the CTPA. And if there are any lighter or grayer areas that's not completely black, then maybe there's an occlusion. There's an occlusion in that vessel that's not letting that bit to fill with a lot of dye. So this is the gold standard, like I said. If CTPA is contraindicated, for instance, like if the person has a severe allergy to the dye or has severe like CKD, chronic kidney disease, then there's an alternative. It's called VQ scanning. So in VQ scanning, we do 2 separate scans. So we do like a ventilation scan, the V scan, and then the Q scan, which is a perfusion scan. So for the ventilation scan, what happens is the person who's doing the scan is gonna make the patient inhale like a gas containing like a radioactive tracer. I think they use technetium, if I'm not mistaken. I'm not really sure what they use, but they make you inhale a gas that contains a radioactive tracer to like see how well air moves in and out of your lungs. So this is the perfusion, this is the ventilation scan, okay? So for the perfusion scan, which is like the second part of this test, this imaging study, what they do is they inject a radioactive tracer in the patient's vein, and they look at the perfusion, so how well blood moves in the pulmonary like vessels, in the pulmonary circulation, and then you compare these 2 scans. So in pulmonary embolism, we mentioned that the ventilation is normal. So the ventilation scan shouldn't have any deficits. It should be normal. But on the perfusion scan, we would see some perfusion deficits. Other additional imaging studies we can do an echo. An echo is going to show us like dilated right ventricle. So the right ventricle becomes dysfunctional because of the increased pulmonary pressure. So the right ventricle is probably gonna be dilated, so it's gonna be bigger. It might even look bigger than the left ventricle, so we can see this on an echo. Another thing we can see on an echo is maybe the IVC, the inferior vena cava, might be maybe a bit like plumpier, because if the right ventricle is dysfunctional, like I said, blood can back up to like the vena cava. So we may see that the vena cava is a bit more plumpier than normal. Another thing we can order like a leg ultrasound. This is for DVT, not for PE. So when you order like a leg ultrasound, a normal deep leg vein would be compressible. So they would use like an ultrasound, and the probe, you'll try to compress the vein with it, and it will show you that the vein is compressible. That's normal. If the vein is non-compressible or non-collapsible, then this may suggest a DVT. And finally, we can order a chest x-ray. So a chest x-ray, it can be completely normal, which should actually raise suspicions. If the patient is hypoxemic, tachycardic, tachypnic, is coughing up blood, has like right ventricular dysfunction, and the chest x-ray comes back normal, then this should raise suspicions. If the chest x-ray is not normal, we may see because of the clot, the tissue, like I said before, the tissue distal to that clot is not going to be perfused enough, so it may die. So this, we may see they might become infarcted, necrotic, and this necrotic infarcted tissue may appear as dark hyperlucid areas on the chest x-ray we call as Westermark sign. Okay, Westermark signs. We may also see a wedge-shaped opacity on the chest x-ray called a Hampton's hump, which we also see on pulmonary embolism. I think the most important bit of the diagnosis is the approach. So how do we actually approach a patient who presents with a potential PE? So I want to look at my notes so I don't miss anything important for this. So if someone presents with query PE, we're not sure if this is PE, the first thing we need to do is we need to calculate the Wells score. So the Wells score is basically helps us identify some of the risk factors or the symptoms that presents if someone has a DVT. So if the patient scores high in this, then we can see that PE is likely, and if they score low, then we can say that PE is an unlikely diagnosis. So I got the Wells criteria here for DVT, so I'm just gonna read out some of the things that we look for. So firstly, we look for advanced cancer, so any malignancies, paralyzed leg, recently bedridden for more than 3 days, or had major surgery within the last 4 weeks, tenderness near a deep vein, swollen leg, swollen calf with diameter that's more than 3 centimeters larger than the other leg, pitting edema in one leg, large veins that aren't varicose veins, previously diagnosed with DVT. So if you score less than 4 in the Wells criteria for a DVT, then we can say that PE is unlikely to be a diagnosis. So the patient is said to have a low pre-test probability. Okay? So after we calculate their Wells score and it's less than 4, so we say there's a low pre-test probability. We do another test just to be sure. We take their D-dimer. So D-dimer, as I said, is a fibrin degradation product, remember? So if their D-dimer is less than 500, then we exclude PE. PE is unlikely. If they score low in Wells score and their D-dimer is low, less than 500, then we exclude the diagnosis of PE. It's probably something else. If, however, the D-dimer comes back and it's more than 500, we refer them to get a CTPA. Okay? Again, if there's CTPA, if the patient has contraindications for getting CTPA, like allergy to the dye or severe CKD, we refer them to get a VQ scan. Okay? So anyway, again, if PE is unlikely because they score low on Wells score, and we do the D-dimer, it's greater than 500, we refer them to CTPA. If the CTPA is normal, then we exclude PE. So we say PE is probably unlikely in this case. If CTPA comes back and it's indeterminate, what we do is we do a pulmonary angiogram or a lower extremity ultrasound just to check. If CTPA comes back and we can see that there is definitely a clot there, then we just treat it. Okay, so that's kind of like the algorithm. If they score less than 4 on the Wells score, if the patient comes to us and we suspect PE, we do the Wells score, we calculate Wells score, and it's greater than or equal to 4. We don't waste time doing D-dimer and any of this. We send them straight for a CTPA. If the CTPA comes back normal, then we exclude the diagnosis of PE. If CTPA is indeterminate, we send them for a pulmonary angiogram or a lower leg ultrasound. If CTPA shows there's a clot, we treat it. So this is the general approach for the diagnosis of a pulmonary embolism. Now let's breeze through the treatment. So there's basically two general approaches. We have to firstly determine the hemodynamic status of the patient. So if the patient is hemodynamically unstable, meaning there's severe hypotension, there's significant hypoxia, jugular venous distension, right ventricular dysfunction, the patient has altered mental status. So in these kinds of situations, what we do is we give them like thrombolytics. Okay, if thrombolytics is contraindicated, we do an embolectomy. So if the patient is hemodynamically stable, meaning they don't have signs of hemodynamic instability, what we give them is we give them anticoagulation. And if that is contraindicated, we put an IVC filter. We also can assess based on the size of the clot. So if the clot is if it's a submassive PE, if it's submassive PE and the patient is hemodynamically stable, then again, what we can do is we can give anticoagulation. If that's contraindicated, we can do an IVC filter. If it's a massive PE, like if it's a saddle embolus, or like if there's a significant clot burden in the patient, then we lean more towards the hemodynamically unstable kind of stuff we use for the treatment. So we can give them thrombolytics, and if that's contraindicated, then what we can do is an embolectomy. Just to quickly discuss some of these treatments. So let's start with anticoagulants. So anticoagulants, the most important thing you need to remember is that they do not break down the clot. Okay, anticoagulants do not break down the clot. That's the job of a thrombolytic. Okay, so what anticoagulants do is they alter the coagulation cascade in a way to stop like the further development of the clot. Okay, so they just stop the progression of the clot. Okay, they don't break down any pre-existing clots. That's not their job. So for anticoagulants, we have three main ones. So we have heparin, we have DOACs, and we have warfarin. So starting with heparin, we have two types of heparin. So we have unfractionated heparin, and we have low molecular weight heparin. So unfractionated heparin is more like it's more used in the hospital, because it's usually given like as a drip or like an infusion. And it's easily titratable, which is one of its advantages in hospital use. And we titrate unfractionated heparin based on their PTT test, okay? So PTT is like partial thromboplastin time. So this is like a measure of how well the unfractionated heparin is working. So if their PTT is too high, so the normal range for PTT, by the way, is 25 to 35 seconds. So if their PTT is too high, if it's higher or longer than 35 seconds, then we're giving them too much unfractionated heparin. So we need to titrate this down. If their PTT is less than 25 seconds, so if their PTT is low, then we can titrate up. So it means that we're not giving them quite enough unfractionated heparin. So low molecular, okay, another thing for unfractionated heparin before I forget. Unfractionated heparin is more likely to cause heparin-induced thrombocytopenia, or HIT, as opposed to low molecular weight heparin. Okay, that's the only kind of like disadvantage. Well, one of the disadvantages. Moving on to low molecular weight heparin. So this is more for like outpatient use, because you can give this as subcutaneous injection. And so with low molecular weight heparin, the only thing you need to be careful of if the patient has like severe chronic kidney disease, you have to be cautious. Low molecular weight heparin is good as a bridge if you're bridging them to like DOACs or warfarin after this course of low molecular weight heparin. Also, it's good because you don't need to measure their partial thromboplastin time. Next one is our DOACs. So DOACs are direct oral anticoagulants. So DOACs, we have two types again. So we have like factor 10A inhibitors. So these are your apixaban, rivaroxaban, and factor 2A inhibitors. So that's your dabigatran. And DOACs are preferred over warfarin because there's like less monitoring involved, there's less risk for hemorrhage, and less drug interactions as compared to warfarin. Warfarin is the last type of anticoagulant we can choose to give. So warfarin, again, it's good for outpatient use. It requires monitoring, so we need to monitor their INR. And INR is usually between 2 and 3, so that's the normal range. If it's greater than 3, then we're giving them too much warfarin. They're going to be at risk of bleeding. If it's less than 2, then we're not giving them enough, so they are still at risk of clotting. It's very important to remember that, especially in the first couple of days, maybe first 5 days of warfarin use, warfarin is actually hypercoagulable. So it's very important to bridge them with something like a low molecular weight heparin, and then bridge them to warfarin, because just to cover them for that first few days when warfarin is hypercoagulable. The second choice for hemodynamically stable patients, if anticoagulation is contraindicated or if anticoagulation has failed, is an IVC filter. So an IVC filter is like a sieve. It goes in the inferior vena cava, that's why it's IVC filter, and it just lets like blood and other proteins up back to the right side of the heart, but then any clots and stuff gets kind of like blocked by that sieve, that filter. So that's how they work. It's not rocket science. For hemodynamically unstable patients, remember we give them thrombolytics. So we can give them RTPA, recombinant tissue plasminogen activator, like alteplase. And what this does, as the name suggests, it's a plasminogen activator, tissue plasminogen activator. It stimulates plasminogen, and plasminogen gets converted to plasmin. And remember that plasmin degrades the clot, especially the fibrin. Plasmin loves degrading the fibrin, so the fibrin forms degradation products like D-dimers, remember? So it works by breaking up that clot. So this agent, so alteplase, TPAs, thrombolytics, they work by actually breaking down the clot, as opposed to anticoagulants, which just alter the coagulation cascade to prevent the further development of the clot. Thrombolytics, they actually break down the clot. So this can be contraindicated for someone like with a brain bleed or something. So if thrombolytics is contraindicated, then we could refer the patient for an embolectomy. So an embolectomy, we thread like a catheter through their IVC, their inferior vena cava, to the right atrium, to the right ventricle, to the pulmonary circulation, and just like suck up the clot that's there. So it's a catheter that sucks up the clot inside the pulmonary. I don't know how to explain it better, but yeah, it sucks up the clot in the pulmonary artery or vessel. We can also give these patients with pulmonary embolism some supportive care. So if they're hypoxemic, obviously give them supplemental oxygen. If they're hypotensive because of that right ventricular dysfunction creating that systemic hypotension, then we can give them fluids just to fix their systemic hypertension, but not too much, because we don't want to overload the right side of the heart. It's already dilated, it's already dysfunctional, so don't go crazy on the fluids. The last thing is like vasopressors you can give as well to fix their hypotension. And finally, let's talk about the prophylaxis of PE and DVT as well, because DVT causes PE. So the first thing we can do, for instance, if someone had like a major surgery or paralysis on one side or fracture, or they just have to be in hospital and they have to be bed rested for a long period of time, what we can give them is subcutaneous low molecular weight heparin like dalteparin, just to decrease the risk of getting a clot in their leg that can travel up to their lungs. The second thing we can do is encourage patients to walk, to ambulate, just to get moving. Remember that muscular milking activity. We need to get that going. You're never gonna forget muscular milking activity after this video. The last one is if they're again still in the hospital and they really can't ambulate. On top of giving them subcut low molecular weight heparin, we can use like compression devices. We can use like a compression socks, like TED socks we use in the UK, or like compression devices. I don't know what they're called, but like you wrap this thing around and you connect it to like a machine, and the machine kind of like replicates the contraction of the calf muscle. Yeah, that's one of the compression devices we can use to prevent the formation of clot, because that prevents the stasis of the blood in the lower leg if the patient can't walk for some reason.